see trees of green, red roses too. I see them bloom.
Welcome to Childhood Cancer Talk Radio, powered by Jack's Angels, where we talk about your experiences, advocacy news, research, and today's heroes for kids. We are here to bring hope to the unthinkable but real experience of a child diagnosed with cancer. Jack's Angels' advocacy mission is to provide a voice for children with cancer to effect change for a more hopeful future for those to come. Childhood Cancer Talk Radio starts right now. Here is your host, Janet Demeter.
Welcome to Childhood Cancer Talk Radio. We have a very special show for you today. I'm Janet Demeter, your host, and it's my honor to introduce you to a new nonprofit biotech company called CC-TDI, the Children's Cancer Therapy Development Institute, and some of their research projects which confront more than one frontier of our science and knowledge today concerning multiple aspects of childhood cancer. Now, if you're new to our show and wonder why the need for it and what's all this awareness about, you're in the right place. It's our goal here to help provide validation, resources, new research information for those already in the childhood cancer community, and at the same time, educate the public on the many issues which contribute to the main complaint we all seem to have about it, not enough research funding for our kids. In fact, it was revealed fairly recently in 2014 that our National Cancer Institute, hero that it is for providing most of the funding for childhood cancer research, gives a shocking and meager 4% at best of its annual research budget. That's right, your tax dollars at work for cancer research for pediatric cancer, the leading cause of death for children in the United States after accidents and injuries. There are many contributing factors to this, and this deficit for our kids is but one symptom of many issues of neglect within our medical research system. So it's not so helpful to point fingers or unleash blame, but rather it's a matter of identifying problems and then figuring out what we can do about it together. So this is not an easy or singular task in the least. There are several standpoints from which action needs to be taken. Number one, awareness of urgent need for solutions for low survival rate cancers, for which there has been little to no progress in a very long time. Number two, recognizing inconsistencies in our system or places where people tend to fall through the cracks, so to speak, repeatedly. And last but absolutely not least, is recognizing these patterns and finding ways to bridge those gaps and bring scientists together with leaders and affected parties to work together to find solutions. Now, what initially interested me about CC-TDI, the Children's Cancer Therapy Development Institute, was I was reading about transparency, parents working with a biotech company that's a nonprofit, working proactively with regulatory agencies and advocates to help find solutions to bridge those gaps, most notably for childhood cancer, the gap between promising research and then actual therapies that are developed for children. And if you don't know, only 2 therapies have been developed specifically for children in the last 30 years, with perhaps the exception of the latest breakthroughs in neuroblastoma, for which I will look to my guests for any necessary corrections. But without any further ado, I wanted to ask, is our scientific director, Charles Keller, on the line?
Hi, Janet. This is Charles. Yes, I'm on the line.
Charles, I'm so glad you're here. I wanted to introduce you a little more fully, but I didn't know if you were there. Okay, I see it now. So Charles is the scientific director of the Institute, and if you don't mind, Charles, I'll just read a little bit of your wonderful expertise here, if you don't mind. People need to know that
For sure.
Your research focuses on the development of more effective, less toxic therapies for childhood cancers, and his special interest is advanced disease that is spread beyond the initial location of the cancer. Charles co-chairs the Brain Tumor Developmental Therapeutics Committee of the Children's Oncology Group and is a member of the Soft Tissue Sarcoma Committee of Children's Oncology Group, and recently completed a 5-year rotation as a standing member of the National Cancer Institute number 1 study section. Charles has authored over 80 scientific publications and is a recognized expert in the biology of childhood sarcomas and the preclinical investigation of childhood cancers. We are also blessed to have with us Jonathan Agin, advocate for kids with cancer and attorney by trade. I'm Janet Demeter with Childhood Cancer Talk Radio on TogiNet.com if you're just tuning in. And suitably for Brain Tumor Awareness Month, I am personally excited to hear about a project for DIPG, diffuse intrinsic pontine glioma, perhaps one of the most devastating and seemingly hopeless pediatric brain tumors, responsible for roughly 80% of brain tumor deaths in children each year, and also the second most common one. Dr. Keller, welcome again to the show. I'm so glad you're here. I just had to introduce you properly.
Thank you, Janet. I really appreciate having us on, and certainly for all that you do for the community and these kids.
Well, I'm glad to be here, and I'm glad to have this show. My hat's off to TogiNet.com for that. But at any rate, so you had let me know about, there were like 3 or 4 important points, two projects in particular, one involving DIPG, and it's called Jack's 12 Pebbles. I was wondering if you could tell us a little bit more about it and what frontiers of our science that it addresses. I mean, it's fascinating from what I've read.
Oh, well, thanks. So Janet, I think when you, so science should always come from a really good clinical question, and one of the questions that we have for DIPG is how to stop the tumor from growing or even make it shrink. I think we know that there are some drugs that will stop DIPG from growing, or at least slow it down. And these are 2 drugs, panabinostat, which just opened as a trial with the Pediatric Brain Tumor Consortium, and then a pre-drug, sort of not ready to become a clinical trial drug called GSK-J4.
Yeah,
both of these drugs. Right. So they both act in a way to reprogram the volume switches of tumors. They broadly change which genes are on or off, and both of these drugs have a common property that they try to make the tumor cells more like normal cells, which would be terrific. But it's not enough probably to use either drug alone. They probably need to be combined with other drugs. The question often is, for an individual patient, what 2-drug combination is the right one to do? I think that probably has a little bit to do with what mutations each patient carries. We appreciate that in DIPG, there happen to be mutations in growth factor receptors. There's one in a growth factor receptor called MET, M-E-T, another one in a growth factor receptor called ACVR1, which is related to Stoneman syndrome, an incredibly fascinating disease on its own. Then there's the receptor PDGF-RA, platelet-derived growth factor receptor A. And so it's often a question of, my child carries a mutation for MET. Panabinostat is broadly good for children who have the histone mutations or not, p53 mutations or not. Should we engage in put all our eggs in a particular basket to do an ACVR inhibitor at the same time as doing panabinostat? And, it would be terrific to have just a little bit of information to make sure that if you go down that path, take all that opportunity cost, the choice between one and another therapy while your child is still in good health and good functioning and would tolerate drugs really well. Wouldn't it be great to do a small little bake-off of the different drugs that might be combined?
For just one moment, I want to let our listeners know that the reason why this time factor is so important is because, isn't it true, Dr. Keller, that when a child is usually put on a certain clinical trial, it takes a certain amount of time, and children with DIPG don't necessarily have a lot of time?
That's right. That's right. Every clinical trial is intended to do the best possible thing for every patient that enrolls. Nobody would enroll a child in a study they didn't believe would help the child or fulfill the goal. But sometimes you don't have a chance to do the second or third clinical trial. You have to pick the best one up front.
So this really helps with that.
Right.
It sounds like.
Well, we hope we can inform those, and so that comes to a little bit to the story of the device that we're hoping to build. Do you want to hear a little bit more of the details of that, or?
Absolutely. Tell our listeners about the device. It's amazing. I mean, that's the other part of the science that's being combined with this trial that's so fascinating.
Oh, well, thanks. Well, so we kind of, this is a little bit of future vision. So maybe what I'll do is I'll sort of describe the world that we're hoping that we see in the next few years. But imagine, unfortunately, your child has been diagnosed with DIPG, and you're not sure which drug combination is the right one for your child. But the pediatric neuro-oncologist, the brain tumor doctor says, well, we have a device, a very, very small device, that we can implant into the brain tumor temporarily on a Friday afternoon. So you go in Friday afternoon at about 3 o'clock, and a small little circular microchip about the size, half the size of a pencil eraser, is placed in the tumor at one particular site. There might even be more than one of these small wafers placed in the tumor. And what it does is it measures in a competition the best possible drug combination that might stop the tumor from growing, but it does it in real time. And so to sort of the reason that it's called 12 pebbles is that it has an analogy to a pond. And so, if I can get everyone to sort of think of a small pond where the water is perfectly still and there's 12 children standing around the pond, each child might hold a pebble, and they would drop that pebble at the edge of the water on the pond.
And I want everyone to hold on to this meditation, because we're going to come right back with you. Hold on to the pond. We'll be right back. This is Childhood Cancer Talk Radio on TogiNet.com. We'll be back after these messages from our TogiNet sponsors.
Stay tuned. Janet will be right back with more on Childhood Cancer Talk Radio, where kids come first for the cure.
Welcome to Geraldine Tegelov Live, the show that shares with you the secrets of redefining, reinventing, and rebuilding your life. Having pulled herself from the rubble of financial ruin and having gone on to create a highly successful career, Geraldine has become an expert in the art of transformation. She believes that it doesn't matter where you are right now, how overwhelmed you feel, or how impossible the task of turning your life around may seem. You can do it. Stay tuned as metaphysician, international best-selling author, and intuitive Geraldine Tegelov gives you the inner understanding and the outer practical how-to to create your amazing life. Gain a fresh perspective on how to redefine, reinvent, and rebuild your life. Join Geraldine Tegelov live every Tuesday evening at 6 p.m. Eastern Standard Time, right here on the TogiNet Radio Network.
Have you heard? The pages of American Patchwork and Quilting magazine come to life on our new weekly online radio show, American Patchwork and Quilting. Join Pat Sloan, our blogging and quilt designer host, as she talks about the latest trends, ideas, and inspirations. Her guests include quilt pattern designers, authors, quilt shop owners, and our editors, all quilters just like you. Call in with your questions. Get quilting tips from industry experts. Learn about free patterns. Hear behind-the-scenes stories from our magazines, American Patchwork and Quilting, Quilt Sampler, and Quilts and More. Get the scoop on free stuff and find out more about the best independent quilt shops in North America. To listen to a live show, tune in Monday at 4 p.m. Eastern. Just log on to allpeoplequilt.com/radio. To hear past shows, go to iTunes and search for American Patchwork and Quilting Radio. We hope you'll join us because we know that quilting changes everything.
You'll always have my shoulder when you cry.
Welcome back to more great conversation on Childhood Cancer Talk Radio, because every child's life deserves hope. Here's Janet.
Welcome back to our show today with the Children's Cancer Therapy Development Institute. I'm Janet Demeter, your host, and I'm speaking with Dr. Charles Keller, the scientific director. And Dr. Keller, before the break, we were discussing this really innovative technique of using a very small chip, and you were describing how the chip works. You put it it gets inserted in the brain tumor. We're talking about DIPG here, which is a brainstem glioma in the pons area of the brainstem. And you were kind of taking us through a little meditation to imagine how the chip works and what it's trying to do. Could we have a little reprise of that?
Sure, absolutely. So the microchip that's implanted to read out the best two-drug combination, well, it's a circle, and the reason it's a circle is that circles have a fabulous function that, as drugs on the edge of them might have different strengths, they make ripples across the chip. And so the analogy was, imagine a pond where the water is perfectly still. There are 12 children standing around the pond, equally spaced, and each child holds a pebble. The pebble is representative of a drug. There are two children whose pebbles are larger than any of the other children's pebbles. And when all the children drop their pebbles in the water on the edge of the pond at the same time, the two largest pebbles, meaning the two most effective drugs, make the biggest ripples. And as they move across the pond, the ripples will intersect. Well, if the microchip wafer is the pond, and what the microchip does is measure the impedance or the electrical conductance of living tumor cells, which changes when the drug effectively makes them not living, then you can deconvolute, or you can uncover, you can pinpoint the intersection between the two most potent drugs' ripples. And on this wafer, which we hope to have near-field communication, it would read out onto the parent's iPhone, starting from the point of time when they go home from the hospital. Well, we hope, right? This is all the way we want it to work. But we're right next to Intel, and they tell us these things are feasible. So if you have the microchip implanted in the tumor, you go home on a Friday afternoon, the family's iPhone or I guess Samsung device, if you wish, Android device, gets a real-time reading of which drugs seem to be the most potent in combination. And that will certainly change from Saturday morning until Sunday evening. And finally on Monday morning, you go in to the doctor and you say, well, Doc, it started out being this two-drug combination on Saturday, but really sort of the most effective combination we see from the device on Monday morning are these other two drugs. And the neuro-oncologist says, sure, that looks great. Let's start that therapy. And so that's the essence of it. It's grounded in a driving biologic problem that DIPG, for a sustained response and potential cure, will take more than one drug at a time. We have probably 11 good ideas of drugs to combine it with, but we want to make sure it's right for the specific child. And how best to know that than to have a implanted microchip doing the readings on the patient's own tumor as small, tiny amounts of the drugs are being tested together. So that's the vision. And I'll sort of stop there for questions, and then we can talk maybe about the practical aspects that'll be happening this summer on Jack's 12 Pebbles project.
Definitely. Well, one of the first things that comes to my mind is this tumor, DIPG. Seems like it has quite a bit of variation within those that it affects, meaning it seems that there are several different types, not necessarily completely different types, but there are certain common mistakes that the genetics make at the markers that you mentioned, but they all can vary quite a bit. So that hence the need for something like this to find the right combination for the individual.
Yeah, that's very well said.
And another question I had was about the possibility in the future. Say this is a promising procedure and therapy. I could just imagine, like we had a couple of times on this show, those involved with the microcatheter experimentation they're doing at UK Bristol, and they're using 30-year-old carboplatin for the enhanced delivery system with microcatheters, because just to let our listeners know, it's very difficult to access this tumor, hence the need to find the right medication. And that's why they're developing this direct delivery system to the brainstem. And I could just imagine, all in one shot, they could find the right drug. They could get the delivery system in there. I mean, this is thinking way ahead, but I can just see that this would have, I don't know, many different applications and collaborations potentially. And I also want to mention, or if you would, because I want it to be done correctly, to let our listeners know that this is definitely a patented chip.
Well, that's right. So the concept is something that we filed a provisional patent on, and we're a 501c3 nonprofit. We're not here to make money, but I tell you, the best way to get something to patients sometimes is to create, test, and prove out a new idea or a new instrument or a new device, and then license it to a company to take it through the full process of developing it into something that can be in doctors' hands and patients' hands. And so that's the reason we filed a provisional patent on it.
Of course. And I wanted to take a moment now to introduce your partner, our other guest today, Jonathan Agin. He is the General Counsel and Institutional Official and Development Liaison for the Children's Cancer Therapy Development Institute. And he is also the Executive Director of Max Cure Foundation. And he is Cancer Knowledge Network and Childhood Cancer Awareness and Advocacy Section Editor and frequent contributor to the Huffington Post. I'll also mention some important legislation that he was key to providing the childhood cancer community. Let's see, where am I here? It was the HR 2720, the Alexis Agin Identity Theft Protection Act of 2013. I remember hearing, Jonathan, when Jack was going through it, that someone was trying to steal the identity of DIPG children. So while it was going on, I heard about that. I just think that's amazing. Jonathan is also the original founding steering council member of the DIPG Collaborative. I could go on and on forever. This man is amazing. He's one of our country's, the United States, foremost advocates for children with cancer, one of my heroes, and a co-founder of this amazing nonprofit biotech company that's committed to bridging that preclinical gap between promising research and actual therapies for children. Jonathan, welcome to our show.
Thanks, Janet. I appreciate the introduction. And as I sit and listen to Charles talk about the device and its future, I sit back and I'm riveted listening to it because for me, I was just a practicing attorney in Washington, D.C. when my daughter Alexis was diagnosed, and I had absolutely no connection with childhood cancer. So it's an unfortunate connection that I have, but as I listen to the discussion and what we can do, hopefully, and what we are doing in the lab, it blows me away that I get to be a part of it and get to try and hopefully work with amazing researchers like Charles and try and help kids that so desperately need that hope. So thanks for having us on and for everything you do.
Of course. Well, especially right now, we're in May, Brain Tumor Awareness Month, and coming up is hopefully our first ever National DIPG Awareness Week. And DIPG has a special connection, I think, with you, of course, because your daughter had it, and also because, and if listeners are curious, please check out an earlier show, February 4th, which is our first CC-TDI show, where they really go into depth explaining the beginnings of the Institute. It's available to you now. Go ahead and download it. But, DIPG, unfortunately, is, I really haven't seen it. I've looked for survivors. They say 1%, just in case someone's out there. But literally, for decades, there's really been very little change in treatment or prognosis. And so the fact that you're getting together with Charles, you're creating this amazing company that's doing these things for kids, really with the most urgent need. I hopefully will get to touch on the one of the other projects that they're working on, also on the show. But DIPG is really special in that people have suffered from it in the dark for a long time, and you've been a real trailblazer for DIPG and also for childhood cancer in general, because doesn't it exemplify in such a horrible way, unfortunately, the neglect that happens with the research funding for childhood cancer? Yeah,
from the time that Alexis diagnosed to where I am now, I've come to different beliefs in terms of where I'm at. When you first hear that your child has a brain tumor, your immediate thought is, okay, let's get the neurosurgeon in and have it removed. And then obviously, as you learn more about DIPG, you learn that there are no surgical options. And then you start learning about the lack of therapeutic options. And it's not from a lack of trying. There have been 200 some odd clinical trials that have been available for kids with DIPG. Just a matter of trying to find that innovation that breaks out of the box that's actually going to be effective and save these kids.
Yes, and you guys are doing it. Let's come back to that in just a few minutes. This is Childhood Cancer Talk Radio on TogiNet.com. We'll be back after these messages from our TogiNet sponsors.
Stay tuned. Janet will be right back with more on Childhood Cancer Talk Radio, where kids come first for the cure.
Secret Cuisines and Sacred Rituals is a quest, a place, and a feast. Join host Vilasi Venkatachalam every week to explore myths, mystique, old medicine, and brilliant modern solutions through a dazzling kaleidoscope of cuisines, cultures, and cures. This is the place where tribes gather, strangers and familiars, to be memory keepers and makers of our evolving, enduring, evergreen, spoken legacy of wisdom and ingenuity. In Velasi's words, when we do old things in new ways and new things in old ways, we paint with an inspired palette, weave our own healing traditions, and become our own guru. Vilasi is a troubadour of secret cuisines and sacred rituals. She collects stories of wisdom, ingenuity, and grit. She believes wellness and transformation happen when you stand at the threshold of delight and discovery. She displays her hidden penchant for drama when she leads the safari at the supper club. Her favorite pastime is to extol the marvels of cuisines, cultures, and cures. To her audience in workplaces, seminars, and salons, her mantra is, be your own guru. She is a biochemist, botanist, and alchemist who likes to churn delightful, useful things from a brew of art and science, ancient and evolving, old medicine, and new cures. Join Vilasi every Friday at 11 a.m. Eastern Standard Time, only here on the Woohoo Radio Network.
If you're ready for a big change in your work, your career, your happiness, your life, it's time for the $1 Million Mindset with Marla Tabaka. Monday afternoons at 2, 1 Central on TogiNet.com. Marla believes that with the right mindset, anything is possible. Join us as successful life coach Marla Tabaka inspires you and her clients to explore, discover, and live your dreams by developing what she calls the $1 Million Mindset. Marla will inspire you to take action on your dreams and reveal secrets to success that will help you realize your own unique power. Tune into the $1 Million Mindset for heartwarming stories with Marla Tabaka. Learn tips and tricks to building a successful business and unlock the secrets to creating a happier, more balanced life through abundant thinking and attraction power. For more information on the $1 Million Mindset, go to our website, marlatabaka.com. That's MarlaTabaka.com. It's the $1 Million Mindset with Marla Tabaka. Monday afternoons at 2, 1 p.m. Central on TogiNet.com.
Welcome back to more great conversation on Childhood Cancer Talk Radio, because every child's life deserves hope. Here's Janet.
And we're back once again with Dr. Charles Keller and Jonathan Agin of CC-TDI, the Children's Cancer Therapy Development Institute. And you can find them on the web at cc-TDI.org on the web. After this very brief advocacy report, we're going to return to our conversation. I just want to let you know that Childhood Cancer Talk Radio is dedicated to providing a form of support and discussion for those affected by childhood cancer, of research information, advocacy news, and a sense of community for all of us who are in some way involved with the struggle for our children to be prioritized in our medical research system. And for those not directly affected, we provide education, awareness, and an understanding that the difficulties for families of children with cancer reflect deeper problems in our society that affect us all, whether or not we're aware. And more importantly, we strive to speak out for our most vulnerable citizens, our children with cancer and other so-called rare diseases, the inadequacies in research funding for children, and the unacceptable realities that this creates for these children and their families right now. And it is May. It's Brain Tumor Awareness Month. And I repeat statistics about childhood cancer and the most deadly brain tumors because, for example, many still don't know that cancer is the leading cause of death in children in the United States after accidents and injuries, and only 4% of our tax dollars allotted for cancer research with the National Cancer Institute target pediatric cancers as a whole. And so, for the leading cause of cancer-related death in children, brainstem glioma, there has literally been no change in prognosis or treatment protocol for DIPG, for example, the pontine glioma, for decades, and the families have been expected to accept that there are no solutions because their lives are basically insignificant to the investors. The value of our children's lives in this equation is not afforded the priceless status it deserves. No. Instead, we are forced to fight for this recognition for them, to fight for our children's lives, and to fight for the future of our planet, because sometimes it seems no one else is. The house is on fire and no one's willing to go hose it down. So it's an exciting time with important legislation for children with cancer needing your support. And May is here. Did you know that brain tumors are the leading cause of cancer-related death in children, yet one of the least funded areas of research, not only by the private sector, but also our government? And this is especially true and telling with a very low survival rate, less than 1%, for DIPG. With unfortunate regularity, parents are told that nothing can be done. The median survival is 9 months. The most recent House resolution is HRES 586, and it needs your support. Sometimes an awareness resolution is just the perfect way to start people talking about an important idea that has been neatly evaded for a long time. Chad and Jack's DIPG resolution, calling for a National Awareness Week for DIPG and its thousands of departed heroes, and brave kids currently fighting to stay alive, and more awareness for the neglect of pediatric cancer in the medical research system. Using diffuse intrinsic pontine glioma as an example, in HRES 586, we learned how the second most common pediatric brain tumor is responsible for the majority of brain tumor deaths in children each year. Yet there's been no progress in its terminal prognosis in over 40 years, with an average of 20,000 years of life lost each year. HRES 586 calls for more consideration of low survival rate cancers, meaning urgency, and years of life lost, meaning children, in the research grant process with NCI. And so I'm going to cut this short today. I also want to say that up for support is also, very importantly, the STAR Act. All this can be found, the current childhood cancer legislation at jacksangels.org advocacy page, or go to the the address childrenscause.org under their action alerts. All right. So I want to return to our talk with our guests today. I was talking with Jonathan a bit about DIPG and the work at the Institute and what possibilities are available to us now. Jonathan, are you there?
Yep, I'm here.
Okay, good. And also, if we could talk a bit about the collaborative efforts and roles in the community for so many organizations and components of what these organizations are doing, like CC-TDI, but also the advocacy groups and family support, they're all necessary.
Yeah, it's a very, very unique time in the childhood cancer community. From the time I started really delving into it and becoming aware of the landscape back in 2008/2009, I've seen a lot more collaboration within the community through various umbrella organizations like CAC2, which is the Coalition Against Childhood Cancer, or the Alliance for Childhood Cancer, with the Action Days, which are about to take place on the 15th and 16th in D.C., and then with more collaborative efforts underway with industry and with regulators and with NCI and NIH. I often look at the issue as like a bicycle wheel with a lot of spokes, and everybody has their spoke, so to speak, that they focus on, and no single spoke, if it breaks on the wheel, is going to derail the bike from moving forward. But those organizations who focus on the spokes of research and then advocacy and family support and working with industry and NCI and NIH to try and move the ball ahead, it all comes to a collaborative effort to keep the wheel rolling and to keep the spokes as tense as they need to be so that we don't lose speed. And there's a lot happening that we can be excited about, and that we can actually have a lot more hope that the equation will change, and that there will be new drugs developed, that there will be drugs that are available. And that's one of the reasons why I'm so excited about what we're doing in the lab at CC-TDI and Charles's vision, because it is born out of the desire to actually try and create clinical trials that have solid science behind them, that are initiated faster, to move the science ahead for kids who need it, and working with the families and with the foundations that we work with, and working with our partners in pharmaceutical companies and all of the individuals who help to make our mission move forward. It is exciting because it's new and it's visionary. And so when we get to connect with people like yourself, Janet, and what you're doing, and we get to tell our story, and Charles gets to talk about these amazing inventions and the research that's going on, I hope it creates this amazing sense of excitement. And, we need all the support we can get. So, as you said,
Absolutely.
Our website is www.cc-TDI.org. And if you're so inclined, I'll put a shameless plug in here. We do have a way for you to donate on the site. So, it's a collaborative effort at all junctures.
Definitely. And after the next break, I'm certainly going to finish some of the announcements, because one of our events coming up is supporting Jack's 12 Pebbles research project that we spoke about in the last segment. And you can also support that project without going through our event or our organization, even simply by going to the CCTDI website and supporting it, because this is an amazing experiment for DIPG. It offers a promise of saving time and getting a more efficacious treatment to these kids, because everything right now really is about for just trying to extend life for them while we do the other biological research. to find causes and conditions and hopefully, of course, a solution. But no, I can't thank you enough. And I'd also like to ask Dr. Keller, because I was also really excited to see some of these other projects that you have going on. I'm looking at, I don't know if I'm going to pronounce it correctly. It's the RH sarcoma, rhabdomyosarcoma. How do you pronounce it?
Oh, right. Rhabdomyosarcoma. Nobody should create an 8-syllable word for a childhood cancer, but it definitely that's what it is, a muscle of childhood cancer. And when it's spread through the body, like with many children's cancers, when they're spread through the body, it's a challenging disease to treat and a difficult disease to cure. But something we're firmly committed to finding a way to make it and the IPG universally survivable. I mean, these are our flagship projects.
Well, I'm seeing that there's a partnership here with a major Swiss pharmaceutical company that would be extremely helpful, increasing therapeutic knowledge by quite a bit in just months. Could you tell us a little about that?
Well, sure. I mean, we're really excited about this, and I'll keep it a little general because the beauty of working with pharmaceutical companies is that you get access to amazing resources. The other part is that, until they're ready for prime time, our partners like to keep things, as confidential as possible, I suppose.
Of course.
And so, right. So just to kind of describe what we're doing in that project in general terms. So we created the world's first genetically engineered mice for childhood rhabdomyosarcoma, and we did it in such a way where we actually went and figured out what the cell of origin was, and whether it was before or after birth, and then we found out what mutations gave rise to what variations. And we learned something really special. It was quite unexpected, but the cell of origin of a childhood cancer seems to convey a memory to the tumor of where it came from, and that memory. Yeah, truly, right? So the word for this memory is epigenetics. So there's this epigenetic memory of where it came from, which affects how it looks under the microscope. But even more importantly, it affects what drugs the tumor is sensitive to. So we had a paper in a journal called Genes in Development where we found that knowing the cell of origin helped us pick a therapy that turns off the main mutation.
That's amazing.
Completely off.
Tell us a little bit more when we come back. Hold that thought. This is Childhood Cancer Talk Radio. I'm Janet Demeter. We'll be back after these messages from our TogiNet sponsors.
Congratulations on being the proud owner of an adorable, soft, cuddly, sweet-smelling, smiling, cooing, hungry, tired, gassy, screaming little bundle of joy. So now what? Where's the owner's manual for this thing? Where are my instructions? Right here. It's Baby and Toddler Instructions with Blythe Lipman on TogiNet.com. Infant care specialist Blythe Lipman has worked with babies for over 20 years and works extensively with new parents, providing workshops, in-home visits, tips, and daily phone calls to ease those frazzled nerves. With Baby and Toddler Instructions, you can get the advice you need on how to survive and enjoy your baby's first year. For more information on Blythe and how she can help you, go to babyinstructions.com. From 32 ways to stop a baby from crying to 14 ways to get a baby to eat and so much more. It's Baby and Toddler Instructions with Blythe Lipman on TogiNet.com. Information about book publishing is power. The power to change your authoring life and the power to change the lives of your readers. So join us for Your Guide to Book Publishing. Everything you want to know but didn't know what to ask. With your host, Dr. Judith Briles. Thursdays at 6 p.m. Eastern, 3 Pacific. You'll hear about statistics, scenarios, and strategies on what to do now. As the book shepherd, Dr. Judith Briles is in. And each week, she will include publishing professionals that will reveal tips and secrets to the author's journey. If there is a book in you, you want to listen, learn, and yes, call in with your questions each week. For more on Judith and what she can do for you, check out her website, thebookshepherd.com. It's your guide to book publishing. Everything you want to know but didn't know what to ask. Brought to you by Author You and the Book Shepherd with your host, Dr. Judith Briles. Thursday evenings at 6 p.m. Eastern, 3 p.m. Pacific.
Welcome back to more great conversation on Childhood Cancer Talk Radio, because every child's life deserves hope. Here's Janet.
Hey, we're back again. I just have a quick announcement. Jonathan had mentioned it earlier. The Alliance for Childhood Cancer will host this year's Childhood Cancer Action Days in Washington, D.C. coming up soon, May 16th, 17th, 2016. Visit the Alliance on Facebook or on the web at allianceforchildhoodcancer.org. CureFest 2016, a national movement, begins with the first steps is September 17 and 18 of this year. Don't miss this event in D.C. If helping our kids with cancer is important to you, CureFest provides a supportive environment where people from all walks of life join together with common purpose. You're not alone. CureFest is a great way to meet others who walk this path, network, and learn more about the possibilities for your role in the movement. And I just want to also quickly say that Jack's Angels Advocacy Mission went to D.C. this week in support of HRES 586, seeking counterpart legislation in the Senate and support from the White House. New blogs, articles, and letters from the trip will be coming out in the coming week. So please check out our news section at jacksangels.org. It's very promising information, people, but please encourage your representative to sign HRES 586 by going to HRES586.com and following the prompts, or childrenscause.org/HRES 586. It needs all the help it can get. It's the first one coming up. I don't know if we'll get it in time, but we're going to try. Now we're back with our guests, Jonathan Agin and Dr. Charles Keller of cc-TDI, the Children's Cancer Therapy Development Institute. Visit cc-TDI.org to learn more. And also one of their projects called Jack's 12 Pebbles needs support, and you can support it directly at cc-TDI.org. Or if you are in Southern California, please check out the Relay for Jack. It's on May 28th and you can check it out at relayforjack.org. It's in our local area in Southern California. And that weekend, there are lots of DIPG Foundation events. And whether or not they consciously wanted to support DIPG Awareness Week, gosh darn it, they are, and we thank them for that. At any rate, back to our guest, Dr. Keller, you were telling us this fascinating discovery that you've made with genetically engineered mice, and how that there's cell memory of the original cell for this particular cancer. Rhabdomyosarcoma, did I say that right?
Exactly so. So, yeah, it seems like the craziest possible thing. I mean, could you imagine going to your oncologist and he says, well, I really don't know how to treat you until I understand what your cell of origin was for your cancer. But that's what we came to find, that when we did this study, I mean, it was kind of an esoteric study to determine the cell of origin of childhood cancer before or after birth, whether it was a mature cell or more like a stem cell, and then what mutations went with certain timings to give the disease. But the bottom line, cell of origin conveys a memory to the tumor cell that affects what treatments work and what treatments would not work or make the disease worse. From that, we found a drug called entinostat, which turns off the main mutation in rhabdomyosarcoma in the worst form, the alveolar subtype. And in doing so, it makes chemotherapy and radiation work a lot better. And so that's actually entering clinical trials. So this got the attention of this pharmaceutical company who said, we don't know very much about rhabdomyosarcoma, but this whole idea of cell of origin helping pick therapies seems very new and very novel. We'd like to get your systems, and we'd like to test them on a few of our drugs. And when I asked them, well, what do you mean by a few? They said 600,000. And so right, exactly, and they felt they felt that childhood cancer seemed like a really good cause, so they'll just give us all the information, and if we want to develop a therapy out of any of them, they're happy to help. Pharmaceutical companies aren't often thought of as the heroes, but I would say in this instance,
this one it is.
Yeah, exactly. So that's that project. We couldn't be more excited, and we'll probably start getting the data from that in the next few weeks. But imagine sitting on top of all that data. It would change by a factor of 1,000 all the knowledge of childhood muscle cancer treatment since the beginning of time. And so our race is to analyze it as fast as possible. And so we're hiring more engineers. Really, it takes engineers and computer scientists to help us get this job done.
Amazing. So people can also support this project as well, correct? On the website?
Absolutely. Sometimes support means different things. Financial support that always helps, but we've run into families where people are experts in big data analysis, and we have colleagues and friends at Intel that give us a lot of good pointers and shorten the path to moving discoveries into clinical trials. So we welcome any member of the community that might want to help out.
It's excellent. So maybe both of you could help our listeners understand how CC-TDI partners with the community and how they partner with a pharmaceutical company and also work with regulatory agencies. I mean, you guys do a lot.
Well, we do, and I'll start out, and then I'll have Jonathan talk about the legislative efforts. But CC-TDI is a grand experiment. We've been around for about 15, 16 months with the mission of trying to get basic science discoveries to the start of clinical trials. So we have 2 drugs from two publications that are going into 5 clinical trial concepts, of which the first clinical trial started the first one started in March, the next one starts hopefully in July, and then there'll be follow-on trials from there. So
the listeners have to know that only 2 have been developed really for 30 years. And so this company in its first year, because of your dedication, because of your focus, you've come up with 2 new ones in your first year that may have 5 different trials. That's incredible.
Well, thanks. But, it's all about accountability. And this is the essence of families. So families who are going through their child having cancer, they have moral authority. In academics where I was for years and years, papers and grants were the currency. But in the end, it's about helping a child, and the best way to do that is to make the most promising drug available in a clinical trial for that child. So we have a ton of pictures in our lab, and just an enormous number of pictures on canvas and other pictures for digital display. The families come in, they talk to our scientists. Our scientists, when they come in the morning, they see the faces of the kids. They may meet some families, and they really get a sense of what it is that we're trying to do, and that there's a certain amount of time urgency, but accuracy, absolute accuracy to make sure the right drug goes in the trial so that no child's put in harm's way without a substantial reason to have hope that their tumor will respond. And of course, to help these families, we like to empower them by providing them information as much as they'd like. And so we have an annual event. We throw on a 1-week pediatric cancer nano course where parents can come in, families, children who survived cancer. We've had a number of them. They can get lectures, be hands-on in the lab, and they get an assignment to write a roadmap for a particular childhood cancer to figure out the shortest path to get that to clinical trials, get discovery to clinical trials. The first roadmap course, nano course, resulted in a publication in Pediatric Blood and Cancer, the flagship journal of the American Society of Pediatric Hematology Oncology. And the most recent roadmap was published in the Frontiers Journal on hepatoblastoma, and that just published a little over a month ago. So it shows that in a space of as little as 5 days, families can become empowered to pick out what are the key aspects of discovery and drug development that need to be addressed, and frankly, where all the investment of time and funds should be.
I'm bringing my 10-year-old daughter with me. She can't wait. She's like, I get to be in a lab? Oh, my gosh.
We'll let her run the drug robot. She'll get to press the big red button. We'll keep her out of harm's way, but she'll get
keep her busy. No, I'm really looking forward to it. Is registration still open for people?
It is. We have a few spots left. Not many, but a few.
Great. Well, tell our listeners where to go if they'd like to. What is there a certain page on the site they should look for?
Oh, it's on our front web page, which is cc-TDI.org. So Children's Cancer-Therapy Development Institute.org.
Perfect. I have another quick question. I hope we have time for it. But there's this issue of using eggs, replacing mice as the go-to test for validating drugs in preclinical experiments. Is this something? This is something you're working on right now?
It is. It's actually our favorite project. It's an engineering optimization project, but if you can imagine that testing any particular drug in mice, in a living organism, it takes, usually 4 weeks to 4 months, and the cost is usually between $11,000 and $50,000. Well, it turns out you can replace a mouse with a 35-cent quail egg.
Wow.
So chicken eggs would work just as well, but quails are smaller, and that makes it a little easier for our robot. But the idea is that every egg, when it's fertilized, it has a membrane underneath the eggshell which captures all the oxygen, and it brings the oxygen to the developing little quail embryo, which a tiny little thing that's probably about 1.5 millimeters tall. And so there's arteries, veins, and lymphatics in this membrane. When you crack that into a dish, then the membrane floats to the top, and you have a living tissue with which to grow tumor cells in an authentic, vascularized, blood vessel-filled situation.
That's incredible.
And you might, it's a lot, and it's efficient. It takes less than a week, and you can test a particular drug to see if it's the right one for each kind of tumor that you're interested in.
Jonathan and Charles, you are both Childhood Cancer Talk Radio's Heroes of the Week. I can't thank you enough for coming. We're completely out of time, and it's my fault, but I just wanted to make sure we let our listeners know about this incredible thing that you're doing. So
You'll
thank
just
you.
have to have
thank
us on
you so
again.
much. Absolutely. Got to have
Thanks,
a part
Janet.
2.
Thank you, John. Thank you.
Thank
Bye,
you.
Janet.
Prioritize our children in the quest for our